This is a very interesting case of a patient who was 75 years old, and he has presented in the emergency department of three different hospitals with a complaint of pain, epigastrium, and sweating. Now, one of the very atypical symptom of the acute coronary syndrome, especially involving the inferior wall, is pain epigastrium, and there will be associated sweating. So this patient has been going to three, four different hospitals, emergency departments, and he has been getting ECGs there. But most of the doctors there, they couldn't actually give any attention to very subtle and very slight changes in the ECGs, which would have been very good if they were picked up early. So here, if we look at this lead, we 4 V5 V3, we see that there is ST elevation, but there is a problem in this ST elevation. This is a concave ST elevation. So this concave ST elevation is most of the time is normal, and if you just concentrate here, there is non-concave and concave. The concave, this one is is not a bad sign. This is not most of the time normal when the J point is going this way up. But in case of the non-concave, this is most of the time shows the ischemia in the ECG. So this is an important differentiation between two type of ST elevation. This one concave, where it is going up, it is dangerous. But here you see these are concave type of ST elevation in V3 and V4. So these are not as dangerous as the non-concave one. So now if we focus on lead V1 and V2, on lead V1 and V2, we will see that there is an ST elevation which is non-concave type. But in case of lead V5 and V6, there is no ST elevation, but V3 and V4 have ST elevation which is concave type, which are not as bad as the non-concave. Now we will focus here in lead V1 and V2, which are anteroseptal. This is non-concave pattern of ST elevation. Now again, let's go back to V1 and V2, and we will try to compare this non-concave behavior of the ST elevation with those present in lead V1 or V2. V1 and V2, they are on the right side of the ventricle, and they represent right coronary artery supply. So now focus at lead V1 and V2. You will see ST is going in a non-concave way or in a convex way upward. So try to focus at lead as ST segment in lead V1 and V2. So let me mark these changes in lead V1 and V2, where you will be able to compare them. Look at this ST elevation. These are non-concave or convex type, which may represent ischemia in the on the anterior side of the chest leads, which are representing septum and right ventricle. Both of these are being supplied by the right coronary artery. So these slight change may point towards some sort of ischemia going on in the areas which are being supplied by right coronary arteries, septum and right ventricle. Now if we try to just keep in mind that out of all the chest leads, V1 and V2 are more towards that area of the heart which is supplied by the right coronary artery. So anteroseptal ischemia is a suspicion in this ECG of the chest leads. Now, if we try to focus on the other parts which are supplied by the right coronary artery, that is the inferior wall. Inferior wall is also supplied by the right coronary artery. Lead 2, 3, and AVF, they represent inferior wall. And if you focus closely, if you look at the ST segment, then you compare it with the isoelectric line. Isoelectric line is between T and P. Between T and P is the isoelectric line. And if you try to focus on the ST segment, is it not going down or depressed one small box? The definition is that if ST segment is depressed one small box or 1 millimeter lower than the isoelectric line, look at here now again to try to focus, then you will see that indeed ST segment in lead 2, 3 and AVF, which are looking at the inferior wall, and that inferior wall is being supplied by the right coronary artery. In them there is again a very subtle or slight change, and that is ST depression. One small box or more than one small box is significant. So we see here that there is an ST elevation, ST depression in lead 2, 3 and AVF. So again this points towards some sort of ischemia in RCA or the right coronary artery. So these ST depression changes in lead 2, 3 and AVF, and non-concave ST elevation changes in lead V1 and V2 represent septum, right ventricle, inferior wall, all of which are supplied by right coronary artery. So if a patient is coming with pain epigastrium and is also having sweating, then we should be thinking something about this. This is the second ECG which this patient had in another hospital. Now try to again focus on lead 2, 3 and AVF. Do you see that the changes are becoming a little bit more prominent as compared to the last ECG? One small box is equal to 1 millimeter in depth and height. So here the isoelectric line, which is between T and P wave, you draw a line and then you will see, is there ST going down as compared to the isoelectric line. This is now become a little bit more prominent. Patient having pain epigastrium and sweating, and this ST elevation, which can be actually overlooked by so many doctors, is actually present in the ECG of the patient. So there is ST depression in lead 2, 3 and AVF, which is being supplied by the right coronary artery, and this is the set of the leads which represent inferior wall. 2, 3 and AVF are the leads which represent inferior wall. Now in this ECG, which is the second one of the same patient in another hospital, let's look at V1, V2. Is there any change over there? If we focus on the lead V1, V2, we see that still there is non-concave ST elevation, and even it has involved lead 3 this time around. Lead V1 and V2, they are the anteroseptal leads. They are watching the septum and the right ventricle, again both of which being supplied by the right coronary artery, and the change is now extending up to the just leads V3. So there is indeed some ischemia. Let me make it prominent in lead V1, V2 and V3. Here you see in the circle that there is non-concave or convex ST elevation going higher. J point is going high, and there is a prominent ST elevation in that part of the ECG. So something is not right with the right side of the heart. Right side and the posterior wall seem to have a compromised blood supply, and we know that these parts are supplied by the right coronary artery. So this ECG was obtained in another hospital. Patient has been going to different hospitals. Now this is his perhaps the third hospital he has visited with the same complaint, pain epigastrium, and being restless and irritable, and patient is having sweating. So here too you see some changes in the lead 2, 3 and AVF, and some changes in the lead V1, V2 and V3. So there is ST depression in lead 2, 3 and AVF. ST segment is depressed. It is going 1 millimeter or more in depth, lower than the isoelectric line. And if you focus here, you can actually figure out that J point has gone down. J point has had a dip over there. Just try to focus that J point seems sinking below the isoelectric line. If patient is clinically having problem and you find these subtle or slight changes, then you need to focus that something is not right with a part of the heart being supplied by one specific coronary artery. Now look at the changes in the lead V1 and V2 and V3. You see that as ST elevation is becoming prominent. Though sometime the criteria changes for the chest lead V1, V2 and V3. Instead of 1 millimeter, it becomes 1.5 or more. 1.5 small boxes and more elevation of the ST segment. But in case of the other leads, it is 1 millimeter or more ST elevation. So here it is more than 2 millimeter or 2 small boxes in height. ST segment has gone up. So again, this ECG shows that this patient should be started a protocol of acute coronary syndrome. This is going to be the next ECG of the patient, and now this has become very clear that there is a very clear ST depression in lead 2-3 AVF, and there is RSR pattern in lead V2 very prominently, broad QRS complexes. So right bundle branch block, then there is left lead 1 is downward and AVF is upward, so this is a right axis deviation, and there is a morbid second degree block where there is a dropped QRS complexes. So this time around patient is developing trifascicular block, because we have already explained that side of the right bundle branch is supplied by the right coronary artery. AV node is in majority of the patient it is supplied by the right coronary artery. So there is a morbid type 2 heart block. There is in lead V2, if you focus, there is RSR pattern and broad QRS complex. There is a right bundle branch block and there is a right axis deviation. So I have encircled these changes. Now if you look at the arrow, here it was supposed to be a QRS complex, but it never appeared. So it's a morbid type 2 block where there is no prolongation of the PR interval, and then there is ST depression in lead 2, 3 and AVF, and there is RSR pattern in lead V2. So this is happening in the same patient on the same day. Patient had pain epigastrium and irritability and sweating, and now these ECG changes are evolving. So now every doctor will be able to recognize that patient is having some problem with the right coronary artery, but in the initial 6 or 7 hours when patient had almost 3 ECG, there was no person to actually doubt that this patient has got acute coronary syndrome and is undergoing this cardiac ischemia. So here it is very clear now that there is ST depression in 2-3 and AVF, and there is a right bundle branch block with QRSR pattern in lead B1 and B2 and broad QRS complex. So this is a right bundle branch block. This is inferior wall non-ST elevation MI, and there is now blockage. So the right coronary artery is affecting the rest of the heart. Now this patient was started anti-ischemic medication, but it was almost 8 to 9 hours after patient had initial symptoms of pain epigastrum, and patient had extreme sweating, and along with it patient was very irritable. But here again patient had another ECG, and this time you can also see there is very clear ST depression in lead 2, 3 and AVF, and now lead 1 and AVL both are downward, so right axis deviation and broad QRS complexes everywhere, and you can see that there is now a clear ST depression. So the cardiac ischemic changes are becoming prominent now, because patient was now almost having all the damages of the late management of the right coronary artery acute coronary syndrome. So now here you can see that this patient is having ST depression in lead 2, 3 and AVF, and patient was being started injection heparin, and patient was put on antiplatelets, which is dispirine, clopidogrel, and patient was giving anticoagulant, which is injection heparin 1 cc IV stat. 1 cc of injection heparin is 5000 international unit, and then patient was put on infusion of 1000 unit per hour, and patient was monitored. But minutes after this, patient went into complete heart block. Patient's SA node, which is 60% of the time is being supplied by the right coronary artery, was not able to conduct to send any impulses, so there is a ventricular escape rhythm. If you see, it's a broad QRS complex with a slurred ST segment, and this time the heart rate dropped to around like 25, and patient wasn't able to have any blood pressure. So in this ECG you see it's a ventricular escape rhythm. Whenever ventricle generates its complexes, these would be broad. These would be broader than 0.10 second or broader than 2.5 small boxes. So look at these broad QRS complexes. These are broad, they are less in number. So how can you calculate the heart rate in case of these very few QRS complexes? You count 30 large boxes, then you count the number of R wave in those 30 large boxes, and you multiply them with 10. That gives you a heart rate in case of complete heart block.